I don't think I've ever seen this group of people so darn quiet when they had an opportunity to talk. My gosh, must be soaking it all in. Well, thanks for being here this afternoon and continuing on with your day. You're going to be seeing some things that you've seen before, but repetition I think is important because we need to see things, hear things multiple times to be able to actually digest it well. This is more of an urgent issue, not protocol specifically related, but we're just repeating this as well for those of you who may not have been here over the last 4 or 5 days where we had this medical center policy change. Any medication that's going to be left at the bedside has to be within medical center policy. So the only thing now allowed to be left that we are providing are rescue inhalers. So any of your Spirivas, your Advair, long-acting beta agonists, steroids need to be then put in a bag and brought back into the med room. It's different locations for different areas of the hospital. At Hillcrest and Thornton, I think, has bins in the back rooms as well. And so those, again, will go into a bag, be put back in that locked room or locked cabinet, and then you'll have to go back and get those when you're delivering those medications again. The albuterol, Atrovent, and Combivent can be left at the patient's bedside in the drawer, again, in the bag with the aero chamber like it has been. But that's only for rescue inhalers. No change in the policy for ventilated patients as far as that MDI being left in the cabinets at Thornton in the drawstring bag, or here in the hospital at Hillcrest in that bedside drawer shut up as well. So just remember that new part of that policy. Reviewing those transcribed orders, if you are a team leader, maybe just help us over this next couple weeks as we make this change, because if someone has used the old terminology to say patient to be self-administering medications at bedside, nursing to follow, then it's going to give that instruction there, and Joint Commission or CDPH might say, well, how come it says here it can be left at the bedside when your policy says it can't? So historically, we had that .RT instruction that we could click on, and it would automatically add those 3 sentences: patient to self-administer, medication left at bedside, nursing to follow. Well, we've changed it now, so that .RT instruction still exists for you to add to the rescue inhalers, but a new .RT has been created that doesn't have medication left at the bedside added to it. So how do we know, number one, if those medications have already been turned over to nursing? We can just look through our floors first thing in the morning, and of course, when you see RT meds way over to the right at the top, nurse administering inhaled medications, we know that those are being followed by nursing. Then I would look at the orders down below to say, okay, this one looks right because the medication's at the bedside for the rescue inhaler, and here it doesn't have medication left at bedside because it's other non-rescue inhalers, so that one looks good. I would just, as a supervisor, look through each one of those where I see my medications at the bedside, look through the orders, yep, everything's good to go, but if I should see a Spiriva or a Combi or a non-rescue inhaler that has that medication at bedside, I'm going to open up that order, modify it, and take that word out of there. Again, the new information that we add, we're going to add to just the admin instructions. Don't add it to the comments. Comments are there if you look for it, but they're not going to show up on that first view of everything. They're not going to show up in the orders area. It would be if you opened up the whole order, you'd be able to see it. But this is what's going to show up in the actual order that the nursing and respiratory is going to see. So when you make that change, you highlight what you're removing, you put the .RT, and then remove that medication to be stored at bedside. The new one again is .RT to RN, no BED. But when you bring it up, you'll see the list of the things there are choices. Anything that starts with .RT is going to be something for us to use, and you'll just see it sitting there. So basically that means RT to nursing, no bedside medication is what that's supposed to stand for. And when you click on that one, it won't have that bedside information in there. So that's just news for the day. So what are the objectives of my regular protocol discussion here? Basically to understand the values of the protocols, learn the common problems, errors, and corrections that we need to make, identify appropriate documentation that we're to utilize when we're doing protocols, know the process of transitioning those medications, correctly chart in the care plan, which I know can be difficult. We've tried to, over the last few months, really focus on learning EPIC and where to find reports and results and look at orders and make transitions of medications. So the care plans have kind of gone by the wayside. We need to kind of ramp that up a little bit more. And deliver the treatment plan in the recommended order of treatments. Cystic fibrosis patients have a lot of medications that are being delivered, and then there's a specific order for them to do so. So why do we have protocols, and why are they important? And really, what are they? Is it just something that we just one day said, let's just make up some rules and regulations and we'll make sure that the doctors follow what we want them to do versus what they want to do? Absolutely not. It's basically a set of standards that respond to the patient's condition so that they're medically indicated for that patient specifically, and then refining, transitioning, and discontinuing and restarting the therapy based on what the patient needs. Patient-driven protocols, not physician-driven protocols. So we can ensure that the resources are utilized appropriately, that the patient gets what they need when they need it, not when the physician thinks they need it. As I've talked about before, when I first started here in 1983, every CABG patient that came out, regardless of their chest x-ray, got ultrasonic therapy times 20 minutes, followed by CPT 4 times daily. And when we implemented protocols, we saw a big change in what was being delivered. Who helps us deliver this protocol, and who helps us deliver this care and not have us standing between an attending level physician and no protocols whatsoever? Well, it's our medical director. First, it started out with Dr. Burns, who helped develop these protocols, and then Dr. Morris. And we don't often have to call him, but he really is the resource for us to say, hey, we're having difficulty with this physician or this patient. We've already approached that patient's physician, and it's gone up the chain of command. Now we need some assistance. If it's a policy issue, we don't have the option to change policy. Only Dr. Morris does. The patient's physician can decline protocols, but not policy. So he's there to support us on those issues. And always, if there's a situation, which come up occasionally, that the protocol doesn't meet that patient's needs, and you really feel strongly that, this just isn't working for this patient at this time frame. We can't alter the protocol to fit the patient. We have to take them out of the protocol. And in that case, if we all agree that it just doesn't fit for that patient, it would be an RT exempt, because we're agreeing with that. It's not the MD powering us to do something that we don't agree with. There's a gray area every now and then the patient just doesn't fit. But in those areas where it's like pretty obvious, this patient doesn't need that CPT, or they don't need that bronchodilator, and they're flat out refusing to listen to a policy or a protocol, have them contact Dr. Morris, and he'll, on a case-by-case basis, make those decisions. We initially saw a 50 to 60% reduction in aerosol therapy and chest physiotherapy. Hey, you got a CABG patient who doesn't need any of this, and we've got a protocol that states it's only going to be done if it's indicated. A lot of therapy was stopped. It went from 7,000 routine therapies such as CPT and oxygen and bronchodilators to less than 2,500 in that month's time. We saw improvement in being able to staff appropriately. Anybody here long enough to remember the swag pile? Okay, well, what that was when we had more therapy that we could do, we had therapy that wasn't necessary. So we went through our little Cardex of patients and treatments and said, doesn't need it, doesn't need it, doesn't need it. And that pile sat on the table for the supervisor to hold on to in case a nurse said, this patient needs a nebulizer, or this patient needs oxygen or something. And it was usually the nurse that probably needed, but that supervisor would go up and verify, is the patient needing some, Lasix, not a bronchodilator, or is it because the saturation monitor wasn't on there properly? And they would identify what was needed at that time. We don't have a swag pile anymore because we do what's necessary for the patient. So there's a catch-22. What do you do when you get busy? Again, we triage according to what's necessary. Obviously, a supervised incentive spirometry is not going to be as urgent as a bronchodilator that's needed. But we've got educated staff that know how to triage their patients. Do we have to play by the rules? Well, when we're all in, one person wins. We all win because the patient is getting what they need. If somebody tries to modify that protocol or go outside the lines of that protocol, they may think it's for the patient's best interest because the patient's complaining, saying, I really don't want to do it this way. I'd rather do it like this, or they're having pressure from a physician. But in the long run, we all suffer because the patient gets mixed messages about what's important. The physician gets mixed messages about the way the protocol runs. So following the protocol as those guidelines that are intended is really more important at the bottom line for the patient. So common errors. We often have problems with titration of oxygen. The orders that we see don't match actually the care that's being delivered. Transitioning that care, making sure that there's been documentation in the care plan, the actual order, and that in CliniVision it matches. The order of the care, and communicating that to staff, not just us in SBAR, but the nursing staff as well. Even though we put something in a care plan and an order, they may be so swamped going from place to place that it might be a situation where the patient says, I want my oxygen back on, and they don't even know we've discontinued it or bother to check a saturation before they put it back on the patient. Oxygen protocol, you're familiar with what the algorithm looks like. It gives us the options to say, hey, did they start out with oxygen, or did you find them on room air? What were their oxygen saturations to start with? Are you going to titrate up or down? Contacting the physician if there's been an increase in the oxygen by greater than 10% on a high flow system, or if you've had to make a couple changes in the course of a few hours, you need to contact the doctor and let them know, hey, they're needing more oxygen. They should be informed so they're not surprised when they walk in the door. But then when do you transition them out of protocol because it's RT exempt? So basically, we came through, over the years, we've added to this list of RT exempts because there are certain patient populations that we can't necessarily titrate by their saturation. If the exempting conditions resolve, such as maybe the patient's got a low hemoglobin, we've exempted them, and it's 3 days later and you have MDIs that you're delivering the patient to, and you see their hemoglobin's now 14, and they haven't had the oxygen for a whole day. You know, text page the physician. Just let them know to get that order off of the orders list. It's not as time consuming to do so. You could send out a text message and hopefully he will discontinue it. I do prefer, and I think most everybody else prefers, that you contact the physician by phone call, have them call you back when there's something that you're discussing about including a new type of care or making an alternative change to the care plan, because he might have questions that texting back and forth could be difficult to do, but simply asking to DC an oxygen order that hasn't been necessary for the last day or two isn't that hard, and we can just follow up to see if it's been discontinued. So what are the reasons that we exempt the oxygen? CO2 retainer, and of course documented CO2 retainer. We've seen an ABG that specifies that this patient does have CO2 retention, and if the physician asks for oxygen per protocol, we want to titrate it. But if he asks for oxygen at 2 liters per minute, we're not going to jump in to try to assist with that because the patient has a CO2 retention on ABG. No code comfort care. There's nothing that we're going to titrate. We're not going to take them off of it if it's making them comfortable. They're usually hopefully getting morphine at that time. And I guess there's that rare circumstance where they go from comfort care to maybe somebody has changed their status. In that case, you would dive back into asking for protocol. Sickle cell anemia. There's evidence that additional oxygen during that crisis can prevent sickling. And so in that case, we don't want to take that oxygen away. And I don't have the knowledge to know when that sickling stops. So I wouldn't feel comfortable calling the doctor and saying the patient hasn't worn it in a day, take it off, because maybe they've worn it throughout the day and I don't know. So that's one where we wouldn't take it away. Acute condition where situations of hypoxemia would be suspected in the middle of a code situation. You got a patient that maybe had a chest tube that just got pulled out. So something that's urgent, you're slapping it on, you're not asking for protocol right away because it may resolve shortly or it's going to be something that's transient. Airway hydration, we know, we keep the airway hydrated, and in that circumstance you may not even need the oxygen, it's just at 28% because we don't have a device that goes low enough. And a home regimen without additional requirements. Short-term therapy like a thoracentesis, severe traumas, that ICU status patient. Order for cardiac purposes. I see a lot of patients exempted from O2 protocol for cardiac purposes, and I never saw a room air sat, nor when I looked at the actual evaluation and this S-bar, and then again into the chart itself, did I see anything but CAD, history of coronary artery disease, but they're in here for trauma. They've been brought here because they were in a car accident. So it should be specific to this admit that they've got something going on cardiac-wise that we're exempting them. Pulmonary embolus, we want to keep that oxygen at the bedside in case that embolus should move. Shortness of breath with low hemoglobin, again, shortness of breath with low hemoglobin. If I walk in, my patient's setting 95 on room air after I've taken them off, heart rate doesn't go up, they don't get short of breath, they feel fine, they don't respond to the change of having removed the oxygen, and the nurse doesn't say they got short of breath. They don't say to you, yeah, but I got short of breath when I went to the bathroom. We take it off. We go ahead and titrate them off the oxygen. It's only if, again, they show symptoms of shortness of breath or changes by taking that oxygen away. Or the nurse has said to you, hey, I noticed that when you went to the bathroom, you got really short of breath. Unable to keep that saturation within physician's specified limit on any type of oxygen device that we have. Maybe the physician would just say, I don't even want your protocol at this point because this guy's going to be difficult to work with, or maybe the ABG doesn't correlate. We wouldn't really know how to titrate if they had that kind of an issue. How many have used the oxygen protocol for pneumothorax? Opportunity to do that. And what device do we typically go for first? Non-rebreather. It's simpler, it's easier, it's quick, it doesn't make as much noise, you don't have to refill the reservoir with water. It gives them a sufficient amount of oxygen to cause that gradient to decrease the size of the pneumothorax. Historically, if a patient's been treated with that larger amount of oxygen, within 24 hours they're going to see a slow narrowing or decreased size in that pneumo. And after 24 hours, that push to get it smaller doesn't really make much difference. So it's really only a 24-hour therapy. If at any point in time, of course, that patient gets a chest tube placed, then you're going to want to just treat them per regular oxygen protocol, because it's just, you've taken out that need to have the high gradient change. The additional, let's see here. PTE patients, we titrate them down to SATs greater than 94, I believe it is, on 2 liters. Down to 2 liters, then we leave it because they take a little bit longer to titrate because their oxygen can decrease during exercise. So that was agreed upon over the years to change it to just 2 liters per minute, and then we would stop the protocol. It'd be RT exempt at that point. EPIC documentation when it comes to oxygen. So what we should see documented on our flow sheets, which used to be in CliniVision, is now in EPIC, is that you find them on their oxygen. They're setting 98%, and within your reevaluation and part of that oxygen titration on your flow sheet should show why you're doing what you're doing. In this case, it looks like we're keeping the patient on the oxygen at 2 liters per minute because our reevaluation says O2 protocol, keep O2 sats greater than 92 as recommended per protocol. But where would the discrepancy be in our protocol?
They're continuing it versus dropping it?
Yeah, they're setting 98% on 2 liters. And again, the next day, 2 liters, continue present regimen. If that's the case, I would expect to see somewhere in a note, nurse states patient desaturates when going to the bathroom, even on the oxygen, or patient desaturates at night. Something that's telling me why we're keeping them on the oxygen and not titrating it down. And the physician's going to ask what our protocol is, and our protocol is to titrate for sats greater than 92, or the physician's specified limit. But if for 2 days in a row we just kept leaving him on the oxygen, he's going to say, well, you're not even following your own protocol. So document why you've done something that doesn't show specifically there. Again, continue on a saturation that's greater than 92%. If you're utilizing other information to make your decision, and you're putting it down in your evaluation, document the time that you did or why it's there. I mean, obviously, if they haven't had a chest X-ray in 3 days and you're doing your evaluation today, you can write what the chest X-ray was, putting the date next to it, so we know you're referring to one from 3 days ago. In this case, someone's referring to their hemoglobin within the evaluation, but their hemoglobin was 11, and the date is the 17th. However, in EPIC, there wasn't a hemoglobin on the 17th. It looks like, assuming they're referring to the one on the 16th. But if we made some changes based on that hemoglobin, it wouldn't be accurate. So if you're wanting to just add that information to add it, then put a note in there saying hemoglobin was from yesterday. Or don't put a hemoglobin at all because there wasn't one the day you did that reevaluation. Supervised incentive spirometry, just kind of reminding people that what we're looking for is an inspiratory capacity, so that when you tell your patient to take that breath in, you're not saying, exhale all your air out and take a really deep breath in as deep as you can, because that volume is going to be different than someone who says, let your air out passively and now take a deep breath in, and getting that inspiratory capacity. What number are we looking for? We're not looking for the normal because we don't expect it to be normal, but we do want to see that it's at least 15 milliliters per kilogram of ideal body weight. And what that equals out to, if I weighed about 140 pounds, it would be about 945. So just kind of getting an idea. Pulmozyme, our protocol is specifically for our CF patients, but occasionally we have patients with a lot of mucus plugging that are being bronchhed on a daily basis, and so they need that intervention with that DNase if they've got infectious sputum. DNase only works to break down degenerated white blood cells, and if there's no infection in those mucus plugs, then it's really not going to do anything. It might just be that you need to be more hydrated. Our MDI protocol is just, again, to remind you about those rescue inhalers, that you do your titration up or down, documenting that on your MAR. And then also in the care plan, they're wanting to know what frequency are we doing it, because our order doesn't say what frequency, it just says per protocol. So reminding you that in that care plan, either Q6 or Q4, so the nurses, she just kind of views it quickly, can see that. So to transition those MDIs over to the nursing, again, we go to that actual order. We click on Modify. We then click on that blue part that highlights, and then we're going to keep the pertinent directions there. Like if it's a steroid, you want to keep where it says to rinse their mouth, or to another one. I think the Spreva actually says the capsule shouldn't be swallowed. nice to know, especially when I was told by Ernie that working at Alvarado the other day, the nurse was handing them the capsule to swallow with their water.
Oh my God.
So why should we be delivering all inhaled medications? Wonder. Steps to transitioning again. You're going to make sure that you let the rest of the staff know that you've already made that transition. You've put it in CliniVision, you put it in the care plan. Don't forget to put it here, because when they're matching up their workload with what's in Epic, and they don't see this patient on their workload, but they see it in Epic, it's like, how come we don't know about that MDI on that patient? This tells you that the nurse has been following it, because we turned it over to nursing yesterday. So don't forget that one little step. Your care plan. So this is a very minimal care plan. That's what it looks like when you're first getting started. If I had a patient with these orders, CPT, oxygen, and bronchodilators, would my care plan be sufficient if it just looked like that? What might I be missing? Yeah, so I've got my my MDIs and my secretion clearance missing. So you would go to your template and you would add those additional interventions under that goal. We have heard your words that it's such small font, it's so much on one page, it just is blurred together, and I totally agree with you. There's limits to what we can do. The way it was built with the outside source template was put into Epic, and their font size is not changeable. They're bringing over indentation farther for the goals to be separated from the intervention is not configurable. The only thing that we could get from them that we can do to make it easier for us is to take the words in each one of those interventions and maybe highlight them by capitalizing them. So I'm going through right now and trying to take the word bronchodilator and capitalizing it. So as you're looking down those interventions, you find it and sticks out. Steer protocol, highlighting that so it sticks out. Yeah?
I wish we could see who puts them in.
We can. We can see who does that, and where you get that is your event log. Right here, when you click on that, it'll show you every intervention goal that's been discontinued, when it was discontinued, the initials of the person who did it, and I think it actually spells out if you click on it exactly who that is. I have been told that we're putting in interventions and we're putting in goals, and they come back the next day and they're all gone.
They're gone. Or there's, CPAP and everything used for an oxygen.
Right, redundancies. And we've kind of laid back on having too much interaction about it right away, because we knew everybody else was going through a learning curve. And if you look at the nurses' care plans, you'll see how they have to put an intervention and a goal for everything they do. So they're bombarded. So we thought we'll back off till they get a little bit more comfortable before we start asking a lot of questions. So that's in play right now. So looking for the standards of care. CF patients have a standard of which they do things. DNase is recommended to be given either 30 minutes before or 30 minutes after the CPT. So why do we do it after? Well, if it's supposed to be 30 minutes wait time, we're not going to deliver the DNase and come back 30 minutes later. It's just not convenient. But DNase does take about 30 minutes for it to actually start working. So you wouldn't want to do the DNase, it hasn't done anything yet, and do the CPT and make them cough it right back out again. So we always do the CPT before we give the DNase. So how do you know exactly what order to give all these therapies? And if you don't work at Thornton that often and you're only transferred over there every now and then, a CF patient came up with this, and it works very well. Just because you walk in the door and they're going, CPT, they've been waiting for you to come in all day, right? So you've got your albuterol and your Atrovent, unless you're just getting one or the other, your hypertonic saline, the CPT for secretion clearance, the Pulmozyme, and then the Toby. So your albuterol Atrovent open up the airways, your hypertonic, which makes kind of a slip and slide over the surface of the airways so the secretions slide out a little bit easier, your CPT to get those secretions to move into the larger airways to be able to cough them out. Clear everything you can that's already there and out. Then you can deposit the Pulmozyme on the remaining secretions so that 30 minutes, actually 4 hours later, when you're actually doing the next CPT, it'll come up easier, and the Toby's allowed to actually work on the infectious sputum that is in there. You'll see an article in the next newsletter about biofilm. Biofilm is not just on your grocery cart. This new Pseudomonas has created biofilm within the lungs of the CF patient, and that's why they have constant infections, because it's protected itself inside that sputum. So it actually has created its own biofilm. The evaluation of evidence on CF patients, I'm running out of time, but this is specifically why they do what they do. They've looked at the evidence-based information and what's great, what's good, and what's not really working. So, does anybody have any questions about what I've gone over or things that have come up that you still have questions to?
I have a question.
Yeah.
When, let's say I'm titrating Phil's oxygen, he's on 6 liters, and I'm doing it in Epic. On the flow sheet, could you go back to the flow sheet?
Sure.
Thanks. So let's say I'm dropping him from 6 to 4 liters. Where do I document it? Because it just says SpO2.
Right.
Let's say I make a change. Where am I
Let's see if I
documenting
can't.
what I found him on, and where am I documenting what my change
Not
was?
as, I'm going to try to find that for you here a second.
That's why I think a lot of them get lucky with 2 liters in it, because I've noticed the same thing.
Sometimes I document twice in a row, like this minute was here,
Oh,
and then
that's
the
good.
next
That's
minute
good.
that I should run.
That's I was gonna say that's what I had been told. That it was a suggestion is you document what you see when you walk in the door, and if you have titrated and left it titrated, then you do it one more time showing that. Or you can put significant data right next to, if you've just come in and you've charted that they're 98 on 2 liters, you can put a note significant data, and then put the note in there that says titrate to 1 liter per minute, or if it's to room air.
So there's no one way to do it as long as we show.
Yeah, I haven't come up with a dual way to do so. I would have to think about how we could get something in there that shows pre and post titration, but because we share those oxygen flow sheets with the nursing staff, I think that was what we were told originally, was that they weren't going to know what to put in there.
So maybe the easiest for nursing to see too is just to do 2 of them.
Yeah.
Just do 2. Back to back.
If you would give me feedback, let me know if that seems like it's really a lot more work than it really needs to be, or if it works okay, or which seems to be the best. And there's a new thing called Protocol of the Month. We're going to be posting a Protocol of the Month just to remind you of some stuff that we don't use very often and things that maybe we have issues with, and just to be looking for those. Thank you.